Good evening, everyone. My name is Ajay Shah. I'm the Executive Dean of the faculty. It's my very great pleasure to invite you all to this wedding. No, sorry, to the, to the inaugural lectures today. It did feel like a wedding, I have to say, when I walked in a few minutes earlier. It's particularly pleasing to see so many family, friends, and relatives. And for all of you, and maybe also for some people in the faculty who don't necessarily go to these events, I usually like to say just a few words to set the context for what is an inaugural lecture and why do we have them. So we are the Faculty of Life Sciences and Medicine, which means we undertake activity in the life sciences, physiology, pharmacology, genetics, you name it, and medicine, a very wide range of areas, and the faculty does pretty well. We are, I think, in the most recent league tables, number 10 in the world. Not that we're competitive, but you know, that's not bad. And a lot of the work that people do in the faculty has a significant impact locally, nationally, internationally, particularly in medicine, but also in other areas. All of this work obviously is undertaken by people working in the Faculty of Life Sciences and Medicine, academics, and to achieve or to be awarded the title of professor is the highest level that an academic can get to in terms of academic career progression. So it is important to recognize and celebrate that achievement for anyone who gets awarded the title of professor. That's one of the reasons that we have an inaugural lecture. The second reason is that it's also a celebration of the faculty and the institution, because everything that the faculty does in the end depends on the people who work in it, the professors and some of the other people. So that's the second reason. And then there is a third reason, which is we like to have a little test for someone who gets a title of professor to see how well can they explain their work to an audience that includes a very diverse range of individuals. So I won't be marking that officially, but maybe afterwards. The proceedings today are that we have two inaugural lecturers. We have first lecture, 25 minutes, exactly. Then we have a vote of thanks. Then we have the second inaugural lecture, second vote of thanks, and then we shall all be rewarded with a very nice reception outside where you came in, outside in the foyer. So those are the proceedings. Without further ado, let me introduce our first inaugural lecturer today, Professor Helen Brough, Professor of Paediatric Allergy. And Helen's going to talk to us about how do children become allergic to food, or maybe some food. Yeah, okay. Helen.
Great, thank you. So, so honored to be here. Thank you so much for everybody who's come, and I'm so delighted to see so many friendly faces in the audience. I'm honored to be here giving my inaugural lecture, and I hope that I will be marked fairly and that I will be able to convey some of the really exciting research that has happened in paediatric allergy in the last 20 years, of which I have been a small part of, and I want to thank and acknowledge the wider group of people that have worked in this area as well. So why do children become allergic to food? We all know that there are lots of children who now have food allergy, and we are hearing more and more children developing severe food allergies. The allergy epidemic is something that we are probably all aware of. I was pretty staggered, however, to see some of the latest figures that 44% of adults, which is 21 million people approximately, and 50% of children have at least one allergic disorder. In the UK, there have been over 600% increase in hospital admissions related to allergic disease in the last 20 years, indicating severe reactions. Food allergy, eczema, and hay fever have trebled over the last 30 years in children. And as we stand, currently 1 to 2% of adults and 5 to 8% of children are allergic to at least one food. And more worryingly, 51% of adults and 42% of food allergic children have had a severe allergic reaction, which obviously has significant impact on their quality of life. And the annual cost to the NHS exceeds £1 billion. Today I'm going to be talking about 6 areas of research. The first is going to be how children become allergic to food. Subsequently, I'll talk about my master's and PhD, which looked at environmental risk factors for the development of peanut allergy. And then after that, what this work has led on to in a large study funded by the US. Then I'm going to talk about a different approach to prevent food allergy, which is about eating food allergens early and often. And then once you have one food allergy, we know you're much more likely to develop more food allergies. So is there anything we can do to prevent that? And then finally, I alluded to the mental health concerns with regards to children and adults with food allergies, particularly after a severe allergic reaction, and what can we do to support them? We're going to start at the beginning with the allergic march. So we know that children initially develop eczema, followed by food allergy, and then some of them develop allergic rhinitis and asthma. So if you have a child with severe eczema, it's important that as they go on through their life, they're screened for some of these other conditions. This was a really large study in Australia looking at almost 5,000 children, and they showed that if a child had eczema or atopic dermatitis, then they had a much higher rate of food allergy. So 6-fold increase of food allergy if they had eczema. And when you look at specific foods, for egg it was 6-fold, peanut it was 11-fold, and sesame it was 41-fold increased risk of sesame seed allergy. So why is this? How are children becoming allergic to foods? And there's been a large body of evidence in the last 20 years looking at why this is happening. And what we now know is that there are certain genetic predispositions towards eczema, which then mean that you're more susceptible towards getting irritants and environmental pollutants, making your skin barrier more impaired. And this is number one. Once you have an impaired skin barrier, you get dry skin. And then once you have dry skin, what can happen is that because water is coming out, you have other things coming in, such as infections or allergens or detergents. And this then leads to inflammation and clinical eczema. And some of the work that's been done in both animal studies and in human studies has shown that there is an association between the exposure to food allergen through dry skin or eczema and the development of food sensitization and allergy. So moving on to the next part, which was looking at environmental risk factors for peanut allergy. I'm going to start with this slide because I think it's nice as it starts with 2 people that were responsible for my career in pediatric allergy. I met Adam Fox when I was a senior house officer. Where is he? Can't find him now. Hello! And he was a pediatric registrar. And I was working in A&E, and I was going to become a pediatric gastroenterologist as well. And then Adam was saying, well, you could become an allergist, and then you can do your gastro interest, but you can also do an interest of the skin, of the lungs, of the nose, because allergy is a specialty, but it affects every organ system. And then I went to one of Adam's fantastic practical pediatric allergy study days, and there I met Gideon, who was interested in my piano playing, and then talked to me about doing some research. And it based all on this paper that was led by Adam and Gideon, looking at household peanut consumption. And what they did was that they took children with peanut allergy from the clinic and compared them against high-risk children that did not have peanut allergy to find out why this was the case. And what they found was that in the children that had peanut allergy, their families were much more likely to have eaten peanut at home in the first year of the child's life. More remarkably, it was actually peanut butter that was the most important food, and they hypothesized that this was because peanut butter spreads around the house and could potentially be transferred onto the baby's skin. So that was done using dietary questionnaires. And the next question was, well, can you actually measure peanut protein in the environment? And that led to the work that I started with Gideon. Now, it was all very glamorous, so we got lots of people to eat peanut butter, and then we would clean the tables and mop the tables and see whether there was still peanut detectable there. Then I went to lots of people's houses and vacuumed their bed. And then we did some specific laboratory analyses looking at the dust and looking to see if we could quantify peanut protein. At the same time, lots of people report reactions to airborne peanut. So we also used an air monitor, which essentially is sucking through air, to see if we could detect peanut protein straight above a peanut packet, above peanut butter, and also directly above shelling peanuts. You can see how close I was shelling peanuts to the air monitor. This was the ELISA. It's essentially a special test, which I like because it's very colorful, and it shows you how much peanut is in the different samples. So that was the premise where I found that actually, yes, you can measure peanut in the home environment. And this then led to my master's. And I want to mention the people that enabled me to do this today, because when I was going for my general pediatric registrar training, I asked Warren Heyer, I don't know where he is, hello Warren, and at the time you were only allowed to do advanced pediatric MSCs, but you fought my corner and allowed me to do this MSc in allergy. And it's through that that then I was able to validate the method, and from that everything else ensued, so thank you. And then whilst I was at Northwick Park, Ahmed Massoud was my educational supervisor, and Fernando Isaza was my mentor and friend throughout that time. I can't see Fernando. Hello. And then my supervisors were Professor Gideon Lack and Professor Graham Roberts. Thank you very much. And then the wonderful MSc organizers were firstly Professor Jill Warner and then Professor Judith Holloway. So during this time, I validated a method to measure peanut protein in the home environment. I showed that you can measure this in bed dust and surface wipes the day after eating. So if you have a peanut butter sandwich today and then sleep on your bed, tomorrow your bed will be full of peanut protein. You can measure it in the saliva and on hands 3 hours after eating peanut, even if you wash your hands. But we did show that it's poorly aerosolized over peanut butter, even over satay peanut cooking, and whilst wearing peanut monitors, you could not detect the peanut. When I was shelling the peanuts, you could measure it, but only briefly whilst you were shelling the peanuts, and then it disappeared, arguing against airborne peanut. So then we moved on to the next stage, where I went to lots of people's homes that had infants, and I vacuumed their baby's bed and play area. And I wanted to see whether this correlated with the household peanut consumption that Adam had found in his original paper. And indeed, you can see that in the infant bed and in the infant play area, if other members of the family are eating peanut, then there will be high levels of peanut in that infant's bed, even if the infant is not eating peanut. Then we wanted to do some further investigations into what is this peanut in the dust? Is it just fragments of peanut, or does it actually do anything? And this initially was work that I did with Alex Santos, and then afterwards with Claire Mills and Dr. Johnson. The first work that we did was looking at whether peanut in dust is biologically active. So can it actually stimulate the cells of the blood of a peanut allergic patient? So we mixed peanut dust with the blood cells of peanut allergic patients, And we found that there was a dose-response increase in degranulation or bursting of the basophils, which is the allergy cell. And so we showed that it was biologically active. And then we used mass spectrometry, which is a really sensitive assay, to actually look at the building blocks of the peanut in the dust. And we were able to show that you can quantify the major allergens that cause the peanut allergic reactions in dust. So naturally, the next question is, what then happens if your baby is surrounded in peanut when they're born? Does this increase their risk of developing peanut allergy? And indeed, it does. This was work that I did together with the Manchester Asthma and Allergy Study with Professor Adnan Kustovic, Dr. Nick Nicolaou, and Professor Angela Simpson. Angela spent hours with me teaching me how to do SPSS in a really powerful way. And it was Adnan who actually detected the interaction between filaggrin null mutations and environmental peanut exposure, just as he walked past the computer. So it was all yours, Adnan. And Nick was just wonderful. He looked after me and was helping me with this. Abdel Douri was a statistician who worked with me on all of the PhD cohort studies and was incredible. We showed from this cohort and other cohorts thereafter that if you have an impaired skin barrier or eczema, then being exposed to peanut in the environment does increase your risk of peanut allergy quite substantially. If you have completely normal skin or you're not high risk, it does not increase your risk of peanut allergy. This is data from the US where we replicated these findings, looking at a high-risk cohort of children where likely peanut allergy and peanut sensitization also increased with increasing environmental peanut exposure. So this is what's happening to our babies. We've got a baby with inflamed eczema surrounded with peanuts. What are we going to do to help children stop becoming allergic to peanut? This is where summary of the PhD, with thanks to my supervisors, Professor Lack, Dr. Michael Perkin, Dr. Victor Tilkanu, for all the help with this. And then my PhD examiners, Professor Hurrahane, Dr. Claire Murray, and then Professor John Warner, who mentored me during PhD, which can be an art. So, peanut concentration in dust is highly correlated with household peanut consumption, contains the major allergens of peanut allergy, can degranulate basophils in the blood of peanut allergic children, and having peanut, bathing in peanut when you're young, increases your risk of peanut sensitization and allergy if you are high risk or you have a disrupted skin barrier. And then I also did some mechanistic work looking at T cells and their particular role in peanut allergy, and we found a particular interleukin, interleukin 9, which is a messenger of the immune system, and we found that it was likely to be related to a particular type of T cell, which is the T helper 9 cell. So this is a picture of the lab team at the top who have all contributed greatly to the laboratory work. Particular thanks to Kerry Richards and Asha Sudra, Alex Stevens and Victor Tilkanu. And then at the bottom there's the leaving party for Martin Penagos, who was a dearly valued colleague and has done wonderful work with us and hopefully will continue to do so. He went to Sweden and helped to get all of the dust samples from an ice cream parlor where they had been stored. So, thank you. Right, now, what do we do next? How do we use all this information? Can we get a child with eczema and change the severity or duration or actually completely clear that child's eczema and thereby prevent them from developing food allergy? This has led to the Stopping Eczema and Allergy study, which I'm very proud to be part of. These are all the principal investigators around the world. There are many in the US, and it is sponsored by Harvard, and it is the National Institute of Health funding. What we're doing here is we're recruiting children with the earliest signs of eczema up until 12 weeks of age. Then they will be either randomized to standard eczema care, or they will have proactive skin care where their skin will be treated with emollients very proactively and also topical steroids to control the inflammation in a way that we hope will maintain normal skin barrier function, thus preventing food allergens from going through the skin and then mounting an immune response that leads to allergy. So that is underway. Very excited about those results. Now, more work that's been done looking at how to prevent peanut allergy is about eating the food early and often to try to prevent peanut allergy, but also other food allergies. And for this, I'm sure you've all seen or heard about the LEAP study, which showed that in high-risk infants, introducing peanut early into the diet, you can prevent peanut allergy by 81% at 5 years of age. Not only that, but over a period of time, and I was honored to be part of all of these 3 studies, it showed that even after avoiding peanuts for a whole year, having eaten them for 5 years, and then eating them however you like, after that, in the LEAP trio study, there was still a substantial reduction in peanut allergy. And in the per protocol group, which is the group that essentially does what we've asked them to do, the effect is still 95% in adolescents at 12 years of age, which is incredible. And these are all of the authors. So maybe this is the solution. Give the child peanut early and often. So even if they have lots of peanut in the environment, as long as they're eating the peanut themselves, they should be safe. And this is the dual allergen exposure hypothesis, which was coined by Professor Lack in 1985 and has borne all of this research. This work shows that in children, there's a window of opportunity in the first year of life, where if you're exposed to peanut through the skin, you become allergic. If you're exposed through the gut, you become tolerant. And this is a photo of all of us when we opened the clinical research facility, the SEAL study, which was a major achievement with a lot of philanthropic funds to build this. Moving on to preventing the spread of secondary allergies if you already have a food allergy. This was work with the ProNut study, where we took children already allergic to one nut, and then we challenged them to all the other nuts with an oral food challenge, where we give the individual increasing amounts of that nut to see if they're allergic or not. We were able to show in this multi-center European trial that there are different predominant nut allergies in different parts of Europe: cashew for Geneva, peanut for the UK, and walnut for Spain. We found that 60% of children had more than one nut allergy. And we also found important links between nuts, including cashew and pistachio, and walnut and pecan. To summarize these results, we know that in the past, people with one nut allergy were told to avoid all nuts and potentially also sesame seed. What we found is that already with doing these challenges, we could show that children are actually usually allergic to 2 nuts and not more than 2 nuts. So most of these children had been avoiding all of these nuts and seeds unnecessarily. And we showed that in the children that were able to safely introduce the nuts that they had been shown to be fine with, they had an improved quality of life. We also looked in this study with work together with Alex to show that the special basophil activation test could reduce the number of oral food challenges. And this is the ProNuts study team. Thank you very much to everybody who's been part of this. Moving on finally to mental health needs of food allergic adults, children and their caregivers. I'm very proud to be part of this multinational study where we are looking at ways to improve access to and availability of psychological services for adults, caregivers and children with food allergy. It is supported by various funders, and we are doing this in 3 phases, of which we have completed the first, which I will present to you, which is an online survey to see what the access is to psychological services for food allergy across the world. Then in-depth interviews have been performed, and these have now been completed, and a follow-up survey is being done to explore further issues. And then the next step, which has started, is development of online resources, now that we know what parents want and adults want from the interviews, to enable people to get what they need to support their needs. This is the phase 1, which just shows the number of adults and children that we managed to get to answer the survey from lots of different countries. And this was a nice poster that was presented at the American Academy, and these are the investigators of the GAPS study, and they showed some very interesting results, which is that a lot of people are experiencing psychological distress related to their food allergy, but very few of them have been asked in clinic, and most of the time it's because of anxiety due to allergic reactions. There are quite big differences across countries depending on the screening for distress and seeing a mental health professional, as well as getting a mental health disorder related to food allergy. The most distress was found in the UK, Australia, and Brazil, and the least distress, and we don't know why this is, was in Germany and France. Finally, I want to talk about some of the specific challenges of being a clinician working in academia, and my thanks to people who have made this possible. So about a year after I became a consultant, I became the clinical head of service, and I was mentored through this process by Gideon and Adam, who left the service in a really good place. But also then I had my baby girl, Catherine, a year later, and this was only possible because Roisin stepped up and took over as head of service in its entirety. Roisin was doing it with me before. And then Kate and Susan supported me through this process as well and became deputy heads of service for the last 6 years and are now wonderful heads of service in their own right. So I would not have been able to combine management in the NHS with academia without their support. And then finally, not sure what happened to that one, these are some pictures of the way that our allergy service has developed over the years. The Allergy Academy is the first picture on the left you can see where we're all very young. And then the 10-year anniversary, which was in 2016 when my daughter was only 3 months old, and I brought her to that. She's in the middle there. And then we've had various strategy days. Hi. Special thanks goes to my parents, Mama and Papa, who have looked after me all this time, supported me, told me not to give up, given me patience. I'm so grateful to you. And then to my pillars on a daily basis, who make me laugh and give me cuddles and make me happy, Dom and Catherine. Thank you so much, and thank you to all of you for coming today.